Hey, it's Medicosis Perfectionalis. Welcome to my CNS Pharmacology course. Let's start with a great introduction on the mysterious world of the brain. So here are the symbols that we will be using throughout this course. This means clinical uses of the drug. This, pharmacokinetics, resistance, side effects, hepatotoxic, nephrotoxic. This means liver enzyme inducer, it's on fire. But this means liver enzyme inhibitors such as P450 inhibitors. This is an oral drug, that's an intravenous, that's an intramuscular. This is topical, this is transdermal. This one is subcutaneous. Drug-drug interaction. The scissors is for surgery. Mechanism of action, contraindications, respiratory depression, respiratory arrest, brain issues, neuropathy, myopathy, cardiac arrest, heart block, hypotension, upper respiratory infection, intravenous infusion, thrombocytopenia, nausea, vomiting, diarrhea, which is gastrointestinal distress, ototoxicity, and this means that a certain drug has FDA black box warning. A serious side effect is going to be written here. Let's start by the basics. Here is your brain. Draw a line in the sand. Anything in front is motor, anything behind it is sensory, with some exceptions. Same thing in the spinal cord. Draw a line in the sand. Anything in front, motor, anything behind, sensory, with some exceptions. For example, the dorsal root ganglion is behind the line. It is sensory. Autonomic fibers and somatic fibers go from here, and they are anterior to the line. They have motor functions. Afferent is sensory, efferent is motor. Look at this, for example. Primary motor cortex is here. If you want to move your arm, this is in front of the line. But if you want to feel something that touched your fingers, this is the primary sensory cortex behind the line. You move your eyes by the frontal eye field. You're able to see and visualize by the primary visual cortex. One is in front, one is in the back. I am talking to you. Talking is a motor function. Broca's area is here. But you understanding the lecture, understanding is a sensory function, so to speak, so it is behind the line. The limbic system is for emotions and behaviors. Hypothalamus has all of the stats or regulations. Thermostat for temperature, glucostat for glucose, apostat for appetite. The midbrain, anything related to the eye and the eye reflexes. The medulla, four very important centers. Cardiovascular center, respiratory center, swallowing and vomiting. Heart, lungs, get it in, swallowing, get it out, vomiting. Spinal cord, micturition, defecation, and erection. During resting membrane potential, potassium is going out. We call this polarization or resting state. That's an inactivation. During activation or depolarization, sodium comes in. When sodium comes in, that's an activation. We call it depolarization. When chloride comes in, this is hyperpolarization or inactivation. Think of it this way. When a positive comes in, it is activation. When a negative comes in, it's inactivation. Let me say it again. When positive comes in, activation. How about when positive leaves? Inactivation. Let's start with the basics of these diseases. Alzheimer's, where's the problem? Degeneration of the nucleus basalis of Maynard. This is responsible for secreting acetylcholine. Now, it's damaged. No acetylcholine. Parkinson's, degeneration of the substantia nigra pars compacta, part of the basal ganglia. It's also part of the midbrain, leading to decreased dopamine. As a result, you will have increased acetylcholine, maybe decreased serotonin. Schizophrenia, dopamine is firing at the mesocortical limbic, specifically the ventral tegmental area, which is part of the midbrain. Huntington's, I have degeneration of the GABA neurons. I have decreased GABA, decreased acetylcholine, but I have chorea. I'm moving a lot. Why are you moving a lot? Increased dopamine. It's also due to decreased GABA. GABA is inhibitory. When there is low inhibition, there is excitation and there is chorea-like movement. Depression, there is low norepinephrine, low serotonin, low dopamine. Everything is low, that's why I'm sad. Decreased norepinephrine at the locus ceruleus, part of the pons. Decreased serotonin, this is the raphe nucleus, part of the medulla. And decreased dopamine is the ventral tegmental area, which is part of the midbrain. Dopamine neural pathways. I have a video on this on YouTube. Please watch it. Dopamine has different functions in different locations in the brain. Nigrostriatal pathway, for example. Dopamine here is for movement. If you have too much dopamine, you will move a lot. Chorea, athetosis, tics, these are hyper-movement disorders. But low dopamine in the nigrostriatal pathway, you get Parkinson's symptom. Everything is slow. Extrapyramidal side effects, these are side effects of antipsychotics. I have problems moving my muscles. Change the location of dopamine, I'll change the function for you. Okay, dopamine at the mesocortical limbic. This is not just one pathway, this is two pathway. Meso means midbrain. So from the ventral tegmental area of the midbrain to the cortex, this is mesocortical. But from the midbrain to the nucleus accumbens, this is mesolimbic, because this is part of the limbic system. Limbic system, yep, emotions, mood, and reward. Too much dopamine at the mesocortical limbic, you get too much emotions, heightened emotions, psychosis, euphoria, hallucination, schizophrenia, etc. Too little dopamine, anhedonia. What's the purpose of life anyway? What are antipsychotics? These are drugs to treat psychosis. No kidding. How do they work? They try to decrease dopamine. When I decrease dopamine, I will cure your psychosis. But as a result, unfortunately, I might lead to anhedonia. Dopamine at the tuberoinfundibular pathway. What's the function here? Dopamine is antiprolactin. Too much dopamine, no prolactin, no GnRH, and no GH. But too little dopamine, prolactin will go crazy because there is no dopamine to inhibit it. I'll get hyperprolactinemia, leading to galactorrhea and suppression of the GnRH. In females, this will lead to amenorrhea. In males, this will lead to erectile dysfunction and gynecomastia. And this is the best table ever. This is dopamine. These are the different pathways. Too much dopamine, this is what you get. Too little dopamine, this is what you get. Let's talk about dopamine agonists. What are their functions? They are trying to increase dopamine. Therefore, they can lead to chorea, tics, acidosis, etc. But they inhibit prolactin. Can I use them to treat hyperprolactinemia? You bet. Let's talk about dopamine antagonists. What are they trying to achieve? They are trying to decrease dopamine. Okay. Can I use them to treat psychosis? Sure, but be careful, they can lead to anhedonia, hyperprolactinemia, and extrapyramidal symptoms or Parkinson-like symptoms because there is just not enough dopamine. Everything has pros and cons. Parkinson's disease is a triad of resting tremors, rigidity, and bradykinesia. Everything is slow, usually to decrease dopamine in the substantia nigra. Alzheimer's dementia is a triad of neuronal loss, senile plaques, and neurofibrillary tangles. Your mood. Let's talk about your mood. Your mood should be around the baseline. If you're depressed like this, dysthymia. Too much depression is called major depressive disorder. On the other way, if you are grandiose and just crazy, hypomania, even more grandiose, and you think that you are ruling the world, this is mania. Major depression is when you sink so deep into the abyss. Dysthymia, what is going on? You are sad but not to the point of being major depressive. How about bipolar? We have two types, bipolar 1 and bipolar 2. In bipolar 1, you swing between mania and major depression. Wow, that's too much swinging. How about bipolar 2? Between hypomania and major depression. How do you treat bipolar? Give me a mood stabilizer to stabilize my mood. What do you call the mood stabilizer? It's like lithium, for example. But be careful, lithium has a narrow therapeutic window, which means it can be toxic. The difference between the effective dose and the toxic dose is minimal. What is cyclothymia? It is cyclic like this, but it's not as much as bipolar 2. It's like between hypomania and dysthymia. Some textbook will say that it's not even reaching hypomania. Some autonomic pharmacology. Let's talk about these fibers. So this is the upper motor neuron, and this is the lower motor neuron. And then what? We have cholinergic fibers here. They secrete acetylcholine to make your skeletal muscles move. What is the receptor here on the skeletal muscle? Nicotinic sub-M. M for muscle. How about if I have cholinergic fiber? It's called cholinergic, therefore it secretes acetylcholine. Example is the preganglionic autonomic fibers. Okay, what is the receptor on the ganglion? It's called nicotinic sub-N. N for a neuron, because this is another neuron. Okay, let's say that this is a parasympathetic fiber. What does it secrete? Acetylcholine. What are the receptors waiting for it? M1 and M2. You found these in cardiac muscles and smooth muscles, but not skeletal muscles. How about preganglionic sympathetic? They still secrete acetylcholine, therefore they are cholinergic. Receptor N sub N on the ganglion, then postganglionic sympathetic secretes norepinephrine on alpha and beta receptors. Let's talk about the adrenal medulla. The adrenal medulla is a modified ganglion, and then you have cholinergic before it, secreting acetylcholine because it's cholinergic, and the receptor on any ganglion is N sub N. And the adrenal medulla will secrete epinephrine and norepinephrine. There is no postganglionic nerve fibers here. The adrenal medulla will just secrete epinephrine and norepinephrine into the bloodstream. Some fibers are cholinergic, they secrete acetylcholine. Others are adrenergic, they secrete noradrenaline or norepinephrine. Let's talk about acetylcholine. It has three options. It can work on N sub N, you find this in ganglia, or N sub M, you find this at the neuromuscular junction on skeletal muscles, or it can bind to muscarinic receptors, you find this on smooth muscles and cardiac muscle. After the acetylcholine performs its job, let's destroy it using an enzyme called acetylcholinesterase. How about here, adrenergic? They secrete norepinephrine, and a pathway goes like this: phenylalanine tyrosine, dopamine, norepinephrine, and stop. But in the adrenal medulla, we have phenylalanine tyrosine, dopamine, norepinephrine, epinephrine. But the nerve ending cannot make epinephrine because it lacks the necessary enzyme. Don't forget, from dopa to dopamine by the dopa decarboxylase. This will be of special importance when we talk about Parkinson's disease. Because as you know, Parkinson's has too little dopamine. That's why everything is slow. Okay, norepinephrine has been secreted. How do you secrete norepinephrine? You have to rupture the vesicle. How do you rupture the vesicle? You need calcium. So this is called calcium channels. How does calcium come in? Sodium has to come in first. So sodium has to come in, cause depolarization of the cell and activation. When this neuron gets active, it opens the calcium channels. Calcium comes in and then releases the norepinephrine from the vesicle. Norepinephrine is here in the synaptic cleft, not to be confused with my intergluteal cleft. Norepinephrine will act on alpha-1 or beta-1 or beta-2. Where is alpha-2? Alpha-2 is here, and alpha-2 is anti-sympathetic. When you stimulate alpha-2, this will inhibit sympathetic release of norepinephrine. The difference between acetylcholine and norepinephrine is huge. How do you make acetylcholine from acetyl-CoA and choline? No kidding. What's the enzyme? Choline acetyltransferase, not to be confused with acetylcholinesterase. These are not the same. This one makes acetylcholine. This one breaks acetylcholine. How do you make norepinephrine? Same story, same song. Phenylalanine tyrosine, dopamine, norepinephrine. If you are in the nerve terminus, stop. If you are in the medulla, continue to epinephrine. To release acetylcholine norepinephrine, you need action potential. You need sodium to come in, calcium to come in, exocytosis, and rupture of the vesicle. How do you remove acetylcholine? By the acetylcholinesterase. You have to destroy it. We have two types of this enzyme. True acetylcholinesterase, you found in the axon terminus, and pseudo, found in the plasma and the hepatocyte. How do you get rid of norepinephrine? First, you try to actively reuptake it back to the neuron, from the synapse to the neuron. This is called recycling or reuptake. Some of it will try to diffuse to the bloodstream, making you alert, and we will destroy the rest by MAO and COMT enzyme, monoamine oxidase and catecholamine O methyltransferase. The action of acetylcholine is very local. Why not general? Because once it leaves that synapse and leaks into the blood, the pseudocholinesterase is gonna destroy it. But norepinephrine is generalized. There is no such thing as an enzyme going around and destroying every single drop of norepinephrine. If you do not believe me, if I get a blood sample from you right now, this blood sample will contain some norepinephrine. It will never contain any acetylcholine. Just trace. What happened to my acetylcholine? All of it has been destroyed by the acetylcholinesterase. Why do you do this? Because if I leave acetylcholine in your blood, it will lead to dumbbells, diarrhea, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, sweating, salivation. To learn more about autonomic nervous system physiology, I have a playlist on my YouTube channel and you can watch it for free. My channel is Medicosis Perfectionalis. What if I want to increase the release of norepinephrine? You can give me a releaser such as amphetamine. Is there any other methods to increase norepinephrine here in the synapse? Yeah, prevent its reuptake. Give me a reuptake inhibitor such as tricyclic antidepressants or cocaine. Is there another method? Yeah, you can inhibit the COMT enzyme, a COMT inhibitor, or inhibit the MAO enzyme called MAO inhibitor. Now let's talk about cholinergic. Let's say I want to increase the amount of acetylcholine available at the synapse. Sure, inhibit the enzyme that destroys the acetylcholine. Oh, you mean give me an acetylcholinesterase inhibitor? That's true. We have reversible and we have irreversible. These are useful drugs. These are harmful toxins, pesticides, and even war gases. So acetylcholinesterase inhibitors are actually muscarinic agonists because they increase the amount of acetylcholine in the synapse. And of these drugs, idurofonium, neostigmine, pyristigmine, we use them for myasthenia gravis, but galantamine, rivastigmine, donepezil-tacrine are used for Alzheimer's dementia. This table summarizes the reversible acetylcholinesterase inhibitors. These are pro-acetylcholine. Don't forget, donepezil and rivastigmine are used for dementia, including Alzheimer's and Lewy body dementia, even vascular dementia. Anti-muscarinics, however, these are anti-acetylcholine. The king here is atropine, and the atropine family is everything that has the word trope in it. Tropocanamide, homatropine, ipratropium, tiotropium, benztropine, etc. Atropine has many side effects, as we'll discuss later. Dry as bone, hot as hair, mad as a hatter, etc. Benztropine and trihexyphenidyl are used in Parkinson's. Why is this? Because remember, what's the problem in Parkinson's? My dopamine is low. My acetylcholine is high. Your acetylcholine is high? I will lower it for you. I will block its receptor. I'm anti-muscarinic. Benztropine trihexyphenidyl. We'll talk about the death of Marilyn Monroe in my barbiturates video. Just remember, barbiturates can vasodilate your vessels, leading to circulatory collapse. Barbiturates can also lead to CNS depression, respiratory depression, coma, and even death. Keep in mind that glutamate is excitatory, but GABA and glycine are inhibitory. Any drug that has the word GABA in it is going to inhibit you, is going to make you calm down. Gabapentin, pregabalin, and vigabatrin. These two drugs are GABA analog. They act as if they are a GABA. They inhibit your central nervous system. Vigabatrin has a different mechanism. It inhibits the GABA transaminase, the enzyme that metabolizes GABA. When I inhibit this enzyme, GABA will increase, and GABA is inhibitory. Glutamate is excitatory, but GABA is inhibitory. Oh, hey, medicosis, why is an excitatory neurotransmitter leading to an inhibitory neurotransmitter? Isn't this a self-contradiction? Shut up, doofus. This is a negative feedback, because too much glutamate, you will have seizures. Your brain will be so excited. You will get neuronal excitotoxicity and die. And that's why when glutamate goes too much, vitamin B6 is going to convert it into GABA to inhibit the glutamate. That's the wonderful world of negative feedback mechanisms. Glutamate is excitatory and it has two receptors. First one is called NMDA glutamate receptor. The other one is called AMPA glutamate receptors, the NAMDA and the AMPA. Glutamate is excitatory. When glutamate stimulates the glutamate receptor, specifically the NAMDA, on a GABA neuron, the glutamate will excitate the GABA neuron. What's the function of GABA neuron? Oh, GABA by definition is inhibitory. So this will lead to inhibition and it can actually treat your psychosis. If you inhibit the NMDA receptor on the GABA neuron, what's going to happen? Now GABA is no longer functioning. GABA is no longer able to inhibit. Oh, I cannot inhibit? What am I going to do? You are going to excitate into psychosis, schizophrenia, etc. And that's why PCP and ketamines can make you crazy. All of these drugs work by inhibiting the NMDA glutamate receptors. That's why all of these drugs are inhibitory. Felbamate makes you calm down. It's an anti-seizure. Ketamine and methadone, they make you calm down. They are anti-pain. They are analgesics. PCP is different because it can make you crazy. It's a drug of abuse. Dextromethorphan is an opiate. We use dextromethorphan for dry cough. It's an antitussive medication. It makes your cough calm down because I inhibited glutamate. Memantine is anti-Alzheimer's, and we'll talk about that later. Serotonin is very important in your brain. If you have too little serotonin, you might become depressed. That's why one of the ways we treat depression is selective serotonin reuptake inhibitor. We inhibit the reuptake of serotonin. Serotonin is going to stay in the synapse. When there is serotonin, you will be less depressed. Awesome. Let's talk about some serotonin receptors. If you stimulate 5-HT2A receptor, by the way, 5-HT is the same thing as saying serotonin, because the chemical name of serotonin is 5-hydroxytryptamine. Stimulate this receptor and you'll get anorgasmia, so the A, anorgasmian. Stimulate this serotonin receptor, 2C, and it will lead to weight gain. 2C, my fat rolls. 2C, my CAG. Stimulate my 5-HT3, it will lead to vomiting because it stimulates the medulla, and the medulla has the vomiting center. I will vomit. The mnemonic is 1, 2. Histamine. When we inhibit histamine, we have two types. We can inhibit H1 histamine receptors or H2 histamine receptors, and these are totally different drugs. If you inhibit H1, you are anti-allergy and anti-congestant. These are the decongestant that you get from your pharmacy. This is what we call antihistaminics. But when I'm trying to refer to an H2 inhibitor, I will not tell you that's an antihistaminic, even though that's an H2 histaminic blocker. I'll just tell you that's an H2 blocker. So again, when doctors say give the patient antihistamine, they mean give the patient a drug that will inhibit H1 and not H2. Okay, what's the function of H2 blockers? Anti-peptic ulcer disease and anti-GERD. Give me an examples of these antihistaminics. Diphenhydramine, dimenhydrinate, etc. These are first generation, and first generation will make you sedated and maybe weight gain. Second generation is better with fewer side effects. H2 blockers include cimetidine, ranitidine, famotidine, and they are drugs to treat peptic ulcer disease, reflux, etc. Here is a case for you. Please pause. So here we have a drug X that increases activity, increases movement, increases grimacing and sniffing. What is drug X? Well, dopamine, especially in my nigrostriatal pathway. Too much dopamine, too much movement. Here is another case for you. Please pause. What is this? This lady cannot keep still. She has to keep moving her legs all the time. Excessive movement of the legs. What is this? This is called restless leg syndrome, and it is associated with iron deficiency anemia. So, how do you treat restless leg syndrome? First, you get a CBC with iron studies. If iron is low, give the patient iron. Most of the time, it will resolve this problem. That's a famous exam question. Case number 3, same patient. You order CBC with iron studies, everything came back normal. So she's not iron deficient. Oh, heating pads and exercise did not help with this patient's condition. What's your first line of therapy in this case? And the answer is pramipixole, another classic exam question. What is the mechanism of action of pramipixole? And the answer here is, it's a dopamine receptor agonist. Case number 4, please pause. So, this is a patient that gets weak, especially on repetitive movement, and she's a lady, and the age is typical. What is this? This is myasthenia gravis. My muscles are so weak. We're talking about skeletal muscles here. Which of the following is likely to be seen in lateral chest x-ray? Myasthenia gravis is associated with thymoma. Which of the following tests is likely to be positive in this patient? And the answer is acetylcholine receptor antibodies. Think of it this way. Here is the neuron, okay? And here is the muscle. The distance between them is the neuromuscular junction. On the muscle we have what? We have a nicotinic sub-M, M for muscle, receptor. Acetylcholine is coming out of the synapse to bind to this beautiful acetylcholine receptor known as N sub-M. In myasthenia gravis, you have antibodies, nasty autoantibodies attacking your own receptors. Now, acetylcholine is not going to be able to bind to this muscle receptor. Your muscle is not going to contract. You will get fatigue and muscle weakness. So you order the acetylcholine receptor antibody test, trying to find these nasty antibodies, but it came back negative. Oops! Which of the following tests is likely to be positive? And the answer is, it could be the anti-MuSK antibodies. So most patients with myasthenia gravis will have antibodies against acetylcholine receptors. Other patients will have anti-MuSK antibodies. Case 5, please pause. So this patient also has ptosis and diplopia, probably muscle weakness, and dyspnea, so we have a lung problem. Cannot chew, could be a muscle weakness. Sexual dysfunction, extraocular muscles are weak. Pulmonary function tests are here. Everything is decreased, except the FEV to FVC ratio is increased. What is this? Restrictive lung disease. So what do you think the diagnosis is? This is Lambert-Eaton myasthenic syndrome. Same story. Neuromuscular junction, nerve, muscle. And then, how do you rupture the vesicle and release the acetylcholine? You need calcium to come in. But in Lambert-Eaton myasthenic syndrome, we have nasty autoantibodies destroying your own voltage-gated calcium channels. So the answer here is B, anti-voltage-gated calcium channel antibodies on the presynaptic neuron. Okay, medicosis, why couldn't this be myasthenia gravis? Let me tell you why. Myasthenia gravis does not have sexual dysfunction. Myasthenia gravis does not have autonomic symptoms. Next question, same patient. Which of the following should be done for screening purposes for this Lambert-Eaton myasthenic syndrome? Please pause, and the answer here is CT scan of the abdomen and chest. Why? Because Lambert-Eaton myasthenic syndrome can lead to small cell lung cancer. I mean, it's associated with cancer, it does not cause the cancer. Question number 3, same patient, previous screening test was negative. Okay, so the CT scan was fine. Which of the following is the best management option? And the answer is plasmapheresis, immunotherapy, and pyridostigmine. Why plasmapheresis? You're trying to wash out the patient's plasma and at the same time wash out those nasty autoantibodies against the voltage-gated presynaptic calcium channel. Immunotherapy, yes, because that's an autoimmune disease. Pyridostigmine. Pyridostigmine is like physostigmine and rheostigmine, etc. is an acetylcholinesterase inhibitor. This will increase acetylcholine in the synapse so that the acetylcholine may be able to bind to the N sub-M receptor at the neuromuscular junction so that the muscle can contract, so that we might treat this patient's fatigue and muscle weakness. Case number 6, please pause. Here is an old male. Vesicular rash below the left nipple extending to the left axilla. Oh, so it's following the same dermatome. I'm thinking herpes zoster or shingles. Okay, you asked the patient about the rash. He mentioned that the rash started 2 months ago, and the pain started shortly after the rash. But the rash disappeared 1 week ago, but the pain did not disappear until this moment. What is this? Post-herpetic neuralgia. After herpes, nerve pain. And this is your answer right here. What's the best treatment option for this patient's post-herpetic neuralgia? And the answer is oral gabapentin. Why not oral amitriptyline? Well, it's true that oral amitriptyline can treat post-herpetic neuralgia, but don't forget, amitriptyline is toxic to the heart, and this patient has a history of myocardial infarction. Don't do it! Last question. 43-year-old male patient was diagnosed with depression and is taking fluoxetine. Today, he presented with dry cough. Which of the following dry cough medication should be avoided? Okay, let's dissect that. What is fluoxetine? Selective serotonin reuptake inhibitor. We're trying to increase serotonin in a patient with depression, which makes sense. Which of the following should not be given with serotonin? I'll tell you. It's dextromethorphan. Why? Because remember, it inhibits the NMDA glutamate receptor. What you did not know that dextromethorphan is also stimulating serotonin receptors. Oh, so this is too much serotonin. When you give two medications together that increase serotonin, the patient can suffer from serotonin syndrome. More cases are coming in the following videos, and all of the cases will be found in the accompanying PDF that you have downloaded with the course. Be well.